Hello, Dr. Rajesh.
Hi, everybody.
Dr. Kane here, Dr. Yadav and Dr. Batra is with me.
Great.
Yeah, welcome.
Great.
And please let us know the case.
Yeah, so I'm going to have my colleagues here present the history, and then we're going to show you the angiogram, and then we'll discuss our strategy and get some help from some of these excellent moderators. And we'll tell you what we have done so far. With your help, we'll be able to finish the procedure.
Yeah.
So go ahead and tell them about the case.
Yeah,
please.
can we have slides, please? He's a 58-year-old gentleman, non-diabetic, had history of angina for class 2 for last 3 years, had inferior wall MI on 27th, and he presented to us around 18 hours later than after the MI. But he was having pain, so we proceeded to angioplasty, and we did the right coronary angioplasty in the acute MI situation. It was very thrombotic lesion. We did the thrombosection, multiple thrombosection, and subsequently we found a good result. Now this was the ECG on the presentation, and then on echo. Next slide, please. Now this is the present day ECG, and then the LV is well preserved. That was the beauty of the angioplasty. He was having angina, but the LV is well preserved. It's a pretty good size RCA, and the LV is good. So we have already checked on the right coronary today, and we did the left angiogram. So we'll proceed to today's angiogram, and then we'll discuss the strategy. First angiogram.
So in summary, this is the patient with an acute myocardial infarction who had intervention to the RCA. It is a patient with acute coronary syndrome and multivessel disease, which is a pretty frequent presentation. And the idea is that a patient who has acute coronary syndrome and multivessel disease should be completely revascularized. So his right coronary artery, of course, was treated, which you can see now on the screen. And we'll show you now the left coronary angiogram. And the left coronary angiography shows that he has a severe ostial and proximal LAD, and he has a severe focal disease at the ostium and a proximal segment of the intermediate ramus branch, and the circumflex coronary artery is without significant disease.
Next.
So the first step here, of course, as you all know, that with the recent data which supports the use of physiological testing to determine which vessels should be treated in patients with acute coronary syndrome and multivessel disease. However, except in one exception, which is the proximal LAD with the severe stenosis, where it still gets a class 1 indication for revascularization, and it does not require physiological testing in majority of the cases unless there is an ambiguity of the stenosis. But what we did here is that we certainly had the question about the intermediate ramus branch. So the first thing we did is the FFR of the intermediate ramus branch, and we'll show you the FFR. Even before giving patient a substantial amount of adenosine infusion, the FFR in the intermediate ramus branch was 0.72. So you can see that on the screen. Can we show that on the screen? Yeah. So that's the FFR of the ramus. So we have one wire in the ramus branch. We have a one wire in the LAD. Yeah. Back to the fluoro. Yeah, so the question that we have been debating here is that whether there is any disease in the left main. You can see that the left ventral descending artery and intermediate ramus branch both comes at a very acute angle. There is quite a bit of space between the LAD and the intermediate ramus branch, and the issue was whether to extend the stent into the left main or not. So in order to resolve that issue in the LAD, we decided to do an OCT.
So what is the opinion of the panel? Is it left main involved or not?
No, it is. I would say that unless you do an OCT or an IVUS, you have to consider that it is involved. Unless you prove it that it is not involved, because ostial LAD is always considered as part of the left main disease, to the best of my knowledge.
Yeah, true. Because none of the ostial LAD is without any left main disease. Almost all ostial LAD will have left main as well.
Go back.
Yeah.
So what did the OCT show? Did
Yeah,
it
so this is
show-
the key. So we agree with you wholeheartedly, and that's exactly why we decided to do a balloon angioplasty of the LED so we can do an OCT run. And now we're going to show this OCT run of the LED into the left main.
Can you run,
So if we
please?
can take the fluoro off and make the OCT picture bigger so everybody can see better.
Yeah.
There you go. So this is in the proximal segment of the LED. Lots of disease there. This is a balloon angioplasty related dissection, some dye contamination.
Dissection.
Yeah. And this is the left main.
Yeah.
Yeah. Yeah.
Go
So you can
towards
see that in this particular case, there is really, left main is not normal, but there isn't really any significant disease in the left main that requires us to necessarily extend the stent into the left main. So the plan is, yes, exactly.
V-stanting looks like will be okay for this case.
Exactly.
Normally V-stanting I don't do, but here the angle is such that V-stanting and the disease in the both ramus and LED will suggest that the V-stanting will be the good choice.
Yeah, so we will place it in a V-shaped fashion, however, without extending much in a way of stent into the left main, and then we'll optimize it with a OCT-based guidance. So we have also done a balloon angioplasty in the ramus, and then we have done a OCT of the ramus branch.
Can we see that?
Yep, that's the next step we're going to show you. This is the OCT of the ramus. Obviously a small vessel. Lots of disease, dissection from the balloon. Long area of disease.
Very fibrous plaque.
And that's your left main.
Yeah.
Yeah. So what is the length? Yes, sir.
In your experience, how often do you get this type of cases where you have no extension of the ostial LED into the left main?
Yeah, it's not very usual, but it's not absolutely
we do
rare.
see cases. Yeah,
Yes,
we do see
yes,
cases.
yes,
yeah.
yes.
So Dr. Raj, as you have rightly said, there is a lot of space between the osteo of LED and ramus. So what is your take about doing two ostial stenting separately rather than doing it simultaneous kissing V stenting?
Yeah, here there is no need for simultaneous V. We're going to put a stent in the ramus branch first, and then we're going to put a stent into the LED.
Absolutely, yeah.
Yeah.
Interesting, because both the lesions don't have any extension into the main vessel. That's a very,
Length?
very, but if you don't do an imaging, then the strategy.
Then it
in
will
this
be much,
patient
much
would be-
harder.
Yeah, then you would
28.
end up, you have to come.
Okay, we'll take a 2.5, 2.533.
33.
Yeah, 2.533.
Maybe. We post dilate that, no?
Yeah, we will have to post dilate in the proximal segment
Yeah.
with a 3O because there is a taper in the ramus. The reference lumen is 2.5, osteally is 3O.
3O.
So we'll put a 2.5 stent in, post dilate at the ostium.
So you're going by the external elastic lamina to external elastic
Yeah.
lamina. is that
Correct,
right? Yeah.
correct, yeah.
And that is 2.44, 2.5. What is?
Yeah, so it's about 2.44 EEL. So once we put, it's easily 2.5
Five,
without a
absolutely,
doubt.
yeah.
Yeah,
Yeah.
yeah, yeah. Chalo, stent de do, sir. Yeah.
So both the lesions don't have much of calcium.
Yeah.
No, there is no calcium in this. It's soft.
Yeah, soft lesion.
Yeah.
Anybody has any, because now let's make it interesting, there's not many people, whoever
Will
are
it
there
go
in
on
the
this?
audience, anybody has any comment or any query, we can, please go ahead. Let's try and make it as interesting as we all can. Is that okay with you, Dr. Raj?
Yes,
Yeah.
yes, please. Absolutely.
Epicardial दिखाना.
Can you use the mic? Yeah. There's a question for you from audience, Rajesh.
Yeah.
Yep, please.
Five. Can you use a drug-coated balloon?
In this
Well,
long lesion?
it's quite long.
Drug-coated balloons
Test please.
can be available long 17 mm like that also.
No, for which lesion are you talking, ma'am? For the
Ramus.
No, but they have already dissected that thing, so
Yeah.
you have to stent it.
Okay,
There's a
very good.
dissection all over.
Let's
so
get it hooked up.
if there was no dissection, maybe they could have, but otherwise. A drug-coated balloon is
Test,
at the
please.
moment used only for restenosis primarily, rather than a de novo lesion. Is that
Need to
correct?
come
Or
back
in
a
your
little bit.
experience, how do you use it, drug-coated balloon?
So in US, as you know, there is no coronary drug-eluting balloon approval.
Okay.
Looks good. Go. Okay. Deflate. Okay, we'll take a 3-0 non-compliant balloon.
Long 3-0. Maybe 15?
So which stent is this?
This was a 2.5 by 33 Zions.
What is your technique to get to the right point? Because it's sometimes extremely difficult to place these stents right at the ostium. Do you have any special things that you
Yeah,
can
so
tell
in
us?
a such a large left main, it's a less of an issue. You know, if there are few struts who are there in the left main, there's no way to make that absolutely perfect. But we can certainly, be fancy and put a wire into the circ, and we can inflate a balloon across it to try to do it that way. But even if you inflate a balloon across in a very large left main like this, you are not going to really get a good. So here, the visual assessment of the lesion and using the clinical experience is the best way.
What about the Zabo technique in this?
What was that?
Zabo?
Zabo technique. We
Yeah.
don't need to be so fancy with this one small vessel. Yeah.
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 So, let me just make a statement. I keep hearing about this technique, and then there are people who say Zabo himself does not use that technique. I don't know what's
Yeah.
the truth.
Yeah.
Probably true. Except in select cases. Yeah.
So this confluence of is so big here that I think a few struts here and there is not going to make
Any difference?
much of a difference.
I
at all,
agree.
and, yeah.
The reason why we decided that we would stent the ramus first is we want to make sure that we don't interact with an LAD stent struts when we are advancing the stent into the ramus. So that's why we thought that get the ramus stent done first, and then we will do the LAD.
It can be done together also, 7 French seats.
Yeah, sure,
Together.
sure, sure.
No, but they're
Then
not
those issues will not be there.
No, but these stenosis are not so close enough to do a typical V
But even then stent, if you want to keep some stent starts into the left main, say 1 millimeter, it may not allow the other stent to go. So it is better to have two
14.
stents together.
16, 18,
18.
down.
You see, it touches the wire of the LED.
No, that's okay.
14.
I think in here I would put two stents separately because then you can concentrate on each stent properly, get it where you want rather than.
Okay. Now. We'll give some nitro now.
Yep. Nitro. NTG.
Here another more. Raj, we have another 4 minutes with you, and then we'll
Okay,
go to
sure.
the other lab. I think you'll be over the case by then, I suppose. But I hope so.
Yeah, we're going to put a stent here in an LID in 5 seconds.
I hope
Can we
those-
have the length of the LED stent? What did we decide? 3 or 38?
38.
Right? Yeah.
38.
Can we have a 3 or
338.
38 Zions, please? I will implant the LED stent in next few seconds,
Yeah,
and then we're going to optimize it with an OCT.
Absolutely. We
and
would love to see the OCT, the
Yeah.
final OCTs and the pictures,
Yeah.
of course. Yeah.
Sure, sure. So discussing about the PCI optimization earlier, this is a perfect demonstration of what really the best of the best care. No problem. We'll put it back in. Test, please. The wires lost the curve. Okay, we'll get it. Test. Test now, so I can see where the LED is. Thank you.
In this case, it would be best to work on the lateral wall of the left main so that you are far away from the stent.
Test.
And this is a point to discuss.
Can we make a epicranial?
Epicranial, please.
Yeah.
Would a LAO caudal view be better? He's already in.
आ गया सर. Okay.
And go to the AP.
LAO caudal now. Okay. Great. Let's hook up, and then we'll do some tests. Let's get this hooked up. Then we'll do the tests. Okay. Test now.
Yeah.
That's good. Do one more picture.
Yeah.
That's perfect.
There was some movement.
Yeah, some movement hai, but yes, there is a little bit of a movement, but we are okay. I'm gonna do one more injection here to see. That's good. Go ahead. 14, please.
So how many of you are doing in the epicaudal in such situation?
AP?
Epicaudal.
Always epicaudal.
Yeah.
Is our
For
choice.
this, yeah, you should see it in, actually, according to me, you should see it in
down.
multiple views.
No,
because
if you
you'll be surprised.
do the LA caudal, it may foreshorten the ostia and you may miss. So it is always better to have epicaudal where it is well profiled.
We're going to do an OCT.
And
so
we'll see that whether it's not.
We're perfectly aligned where we should be. I can almost guarantee that it's going to look perfect. Okay. So, what was the proximal LED diameter? No, before we do the OCT, we should optimize it. So, in the original LED run, proximal LED diameter, please.
3.5 का balloon ला के रखो.
Because this is a 3.0 stent, obviously the prox LED is not going to be 3.0. It's going to be either 3.5 or a 4 millimeters. So come back on this side around 42, right there. Okay, give me EEL to EEL there.
So 3.25 or 3.5.
It's almost a 4.0. So we'll take a 3.5 balloon.
Yeah, 3.5.
3.5. Yeah,
20.
3.5, 20 is good. Yeah. Because there is no point in doing the OCT. Well, we already know that it's not going to be fully expanded. So we'll go ahead and post dilate first, then we'll do the OCT.
So what's your expectation, Raj? Will there be any distortion of the Ramus stent, or you think there is a sufficient distance that
There is a lots of
just
distance,
keep
and
it
there's
over.
not going to be any interaction between the two. Yeah,
it
should
looks
be
like
fine.
that,
Yeah.
looks like that, yeah. With your permission, can we just move on to the other lab and we will come back
please.
to see the final result?
Sure.
Okay, sure. Yeah, sure.
Yeah, sure. Yeah, Rajesh, we are with you.
Okay, great. So we're all finished. You can see the angiogram on the screen. We put in a 2.5 stent in the ramus, which was post-dilated in the proximal portion with a 3.0. We put a 3.038 Zions in the LED, which was post-dilated with a 3.5 in the LED. And now we'll show you the OCT run in the LED.
So we post-dilated with the up to 20 atmospheric pressure. So that at 20 atmospheric pressure, it is going to be a 3.75, as mentioned in the balloon.
So can we show the OCT run now? So you can see OCT run, there is a stent rendering at the bottom, and this is a really nice feature of the latest OCT machine, where you can see the entire stent white and well expanded, and there's no malapposition, there's no under expansion. And if you and you'll see a left main coming here in the view very quickly, and you'll see practically there are no struts in the left main. And you can see the far field, the ramus, and the left main is widely patent, and the stent is fully expanded. So we completed, the case. There isn't anything else we thought needed to be done.
Next.
And we're actually going to take this patient off the table.
One thing I want you to comment on,
Next.
Yeah.
your experience, that even I have done this many times, that if you have an ostial
Next.
LED, and in the left main is so large, and there are multiple vessels coming, and you don't want to go crossover. If you do an IVUS or an OCT, and if you can see no disease in the left main, I think it is the best way to stent this.
Yeah, that is
Yeah.
that is a
Yeah, there is
utility
no
of.
need to
Yeah.
complicate this procedure, because in this case, extending the stent into the left main would have been a hugely complicated part, because this left main is 5+ millimeter in diameter.
Absolutely.
The reference lumen of the LED was only 3.0.
Yeah.
So we would have to then, totally post-dilate the stent beyond its, capacity. If we had the Zion Sierra, then we could do that, because Zion Sierra can be taken up to 5.5. But we would have really stretched the limit of the stent. So I think this is the best way, and I think patient's doing great. He has no EKG changes. His hemodynamics are good, and we appreciate your attention.
Thank you very much. Nice case. Thank you very much.
Thank you very much.
Take care. Thank you very much.